All right, let's talk about failure to thrive. So the differential diagnosis for failure to thrive is pretty extensive and it involves basically every system. However, a lot of times within the hospital, it revolves around social issues or just need for education on feeding. Predisposing conditions are quite a few: prematurity, developmental delay, congenital anomalies, intrauterine exposures, lead poisoning, anemia, malabsorptive processes, anything that increases the metabolic rate, most organic diseases, and social concerns. So as far as the pathophysiology behind it, so basically one of three things are going to be occurring. Either the patient's not taking in enough calories, or they're taking in enough but their metabolism is burning it up for whatever reason, or they're taking in enough but they're not able to absorb them. Clinical manifestations, the biggest thing is that you're going to look at the growth chart. You will see that the weight is less than the second percentile for gestational corrected age and sex, and the decreased velocity of weight gain is disproportionate to the growth in height. And so you may also notice some other physical findings such as decrease in subcutaneous fat, temporal wasting, so that means there's not a lot of fat around the face, and so the face is more in a triangular appearance. And then depending on if there's any underlying etiologies, you may see signs or symptoms of that on exam or by history. You may also see on the growth chart that they drop below 2 major percentiles from their previous weight, and that's also a sign of failure to thrive. As far as the evaluation goes, if the history and physical is relatively unremarkable, then you may not do really any evaluation. And then, however, if there are concerning symptoms or signs on exam, then you would evaluate based off of those. However, every patient admitted will get a social work, nutrition, and OT consult. The social worker will evaluate for any psychosocial needs or stressors. The nutritionist will take a good feeding history, and then they will calculate the calories that the baby is reportedly getting at home. And then they will turn around and calculate out a feeding plan and let you know the calories that will need to be consumed for adequate weight gain. And then we consult the OT person for a feeding evaluation to look for signs of reflux, signs of dysphagia, those kind of things. If we do want to do a lab workout, we start kind of broad. So as you see here, CBC, CRP, SED rate, that kind of thing. You'll notice I mentioned refeeding syndrome. So refeeding syndrome is something we see in children who have been poorly nourished for a long period of time. And what happens is when we start feeding them, we get an insulin spike due to the carbohydrates and sugars. And that insulin spike drives in magnesium, phosphorus, and potassium intracellularly, which then can lead to complications. And so we have to monitor for that when we're improving their diet. We also may get genetic studies as part of our workup, and then infectious studies. HIV is still a player in pediatrics. Chest x-ray may help if we're looking at a cardiac evaluation. For stool studies, this would be important for anything malabsorptive. So we might look at fat in the stool, blood in the stool, reducing and non-reducing substances, and then thyroid studies can help with other metabolic issues as well. So your treatment is basically going to fall around your nutritional recommendations, and then you're going to see if the patient can take it or not. If the patient's unable to take it, it may be that you can increase the amount of calories with what they are able to take, and then in that way they can gain weight. Or if they're just unable to take enough, period, then you may have to look at placing an NG or using a G-tube to get them their full nutrition. And then lastly, you want to monitor for refeeding syndrome when that is of concern. And this concludes our talk on failure to thrive.